Hi everyone, welcome and thank you for taking time out of your busy schedules to join us for this live webinar, Polycystic Ovarian Syndrome. This session is part of Managing Diabetes, ARHP's 5-part course on the reproductive health implications of diabetes. My name is Priya and I am the Membership and Education Associate at ARHP. I will be moderating this webinar. Before we begin, I'm just going to make a few housekeeping announcements. If you called in using a phone and you get disconnected, please dial back in to the number listed in your GoToWebinar registration email. If you have immediate questions regarding the webinar technology, please type them into the chat box on your screen. There will be a question and answer session at the end of the presentation. We look forward to answering your content-related questions at that time. An hour after the webinar, you'll receive an email from GoToWebinar with a link to the post-test survey. Your continuing education certificate will be generated upon completion of the survey. You will receive a follow-up assessment to gauge how you've integrated competencies into your practice. Finally, please note, this session is being recorded. The recording will soon be available to view on demand on the On-Demand Webinar section of ARHP's website. At this time, I would like to introduce Anishi Parker, today's presenter. We are thrilled that she could join us today. Anishi Parker is a women's health nurse practitioner who currently works in Northern California's North Bay Healthcare in OBGYN. She graduated from Boston College with an MS in nursing and received a Master of Public Health from Johns Hopkins Bloomberg School of Public Health. To read more about her experience, please check out her full bio in the follow-up email to this webinar. Anishi, you have the floor.
Well, thank you so much, Priya, and thank you everyone for joining us today. This presentation was made possible by Merck's educational grant, and you will see a list here in just one moment once I get this going, of the different people who helped develop this presentation, and none of us have any disclosures. So just one second here. Let me see if I can get the mouse going, which they told me 100 times how to move. So just one second. Okay, doing what they said, which is this lovely left click, and let's see if we can get this here. Okay, okay. Okay, so the people while I'm working on left clicking, like they told me, are Laura Elizabeth Britton, Lori Garin, and Bimla Schwartz, Diane Shannon, and Raina Solomon were all part of this development here. And it looks like we are starting to activate here, so that's great. Okay, so why are we going to spend the next hour talking about PCOS, and what are our learning objectives? Let me start with this quote that was posted on PCOS Foundation's discussion board by Angel, who's 23 years old, and she called it beautiful and alone. About a month and a half ago, I was diagnosed with PCOS, and I really don't have much of a support system. I'm still able to have kids when it comes to time. I feel like my womanhood is getting snatched from me, and that there's nothing that I can do about it. I've been on a search for things that help me lose weight, cope with being diagnosed, things that one will help me with having children. Any information that I can find would be helpful. So there's the other 5 million women in the U.S. It's the most common endocrine disorder among women of reproductive age, and the prevalence. And the point is that patients are concerned about how to feel normal, how to live a normal life, and are scared about their future sometimes. And that makes sense given the fact that PCOS can increase their risk for obesity, infertility, type 2 diabetes, to name a few. So my goal for today, when you have a patient before you who has irregular periods and hirsutism or treatment-resistant acne, you think PCOS. Specifically, our learning objectives are going to just be describing the prevalence and burden of PCOS, reviewing PCOS diagnosis and management, talking about how to counsel women about taking birth control, and then reviewing some resources for you and the patient. Okay, how are we going to accomplish this? Well, we have the agenda here. We're going to start with an overview looking at the prevalence, pathophysiology, complications, talk about diagnosis, and then managing various issues. We'll have a case study, some resources, and I give you a chance to ask questions. Lucky for you, my 3-month-old slept through the night. My 2-year-old didn't aimlessly wander through the night as well, and my 4-year-old slept through till 6:45, so I think we're in good shape to actually accomplish our goals today. So, like I mentioned, PCOS is the most common endocrine disorder affecting women during their reproductive years. The key features are hyperandrogenism, so hirsutism, acne, elevated testosterone levels, for example, chronic anovulation, and some people also have cysts in their ovaries. The thing for us to remember is that it has a heterogeneous presentation and no one-size-fits-all. So you can have an obese woman with excessive hair growth and also have a woman with a normal BMI with menstrual dysfunction and polycystic ovaries, and both of them could have PCOS. So why is it called PCOS? After all, not everyone will have polycystic ovaries, and seeing polycystic ovaries and alternate syndrome. The polycystic ovarian syndrome, and they look all confused, wondering, did you just throw a tongue twister at them? Are you swearing at them? It's not really informative. And so I actually agree with NIH in its recommendation for trying to change the name and brand it a different way where it represents more of the full clinical manifestations of the syndrome. Some of the risk factors for PCOS are heredity, so a baby born to a mom with PCOS, impaired glucose tolerance, type 2 diabetes, gestational diabetes, metabolic syndrome, to name a few. What is PCOS? Well, there's a short and long answer to that, and you will be able to see that in a minute once this starts working again. But the Cliff Notes answer will be no, there's not a single cause, no single environmental substance or gene identified. The long answer, hopefully this diagram will pop up one of these days, and you'll see that there's genetics and lifestyle that automatically are going to lead to hormonal changes going forward, so you can see my beautiful diagram here. Let's see. It was working. It was obeying very nicely just a minute ago. So I'm going to keep slowly do its job. But what I want you to and that actually these irregular periods are as they approach fecal experience. So most of the women will have oligomenorrhea and amenorrhea. Sorry, this slide's not going back. But most of them will have those. Oligomenorrhea, remember, are cycles over 35 days. Amenorrhea is absence of menses for 6 months. And they could also have this really heavy bleed that comes from not having regular cycles, so dysfunctional uterine bleeding. And along with the anovulation, about 40% of patients are going to have infertility, and that's actually the most common cause of anovulatory infertility. Now, let's see if I can actually get this slide back so you can fully appreciate. Oh, there it is. Okay. Okay, so you can see here the genetics and lifestyle leading to hormonal changes and the elevated androgens and insulin that I was talking about. You can see the hirsutism, the menstrual disturbance, elevated diabetes and cardiovascular and metabolic risks that come with PCOS. Okay, so now we're going to go onto the right side. You see the diabetes here. it is 2 to 5 times increased risk. International diet cause PCOS a significant non-modifiable risk factor for developing type 2 diabetes. And about 3 to 10% of your PCOS patients are going to have undiagnosed diabetes. So when you're thinking about working up a patient for PCOS, you also are going to be thinking about looking for impaired glucose tolerance or type 2 diabetes as well. Obesity itself is going to increase hyperandrogenism, hirsutism, and fertility independently, and will also make PCOS worse, hence you see the diabetes and the cardiovascular risk. Some people actually think that PCOS is a sex-specific form of metabolic syndrome. Okay, so let's look a little bit about the pathophysiology. This will probably bring flashbacks to when you were in grad school and you were starving and got very little sleep. But I think it's worth our time just so that when patients ask us, well, what is PCOS from, we can just have something to go off of. So there are numerous abnormalities. And what is happening in PCOS is you have elevated LH secreted from the pituitary that then ultimately will lead to elevated androgens. So normally you would have in the hypothalamus the GnR is secreted, it goes over to the pituitary, and the pituitary will secrete the LH and the FSH. The LH runs its little cells over to the theca cells in the ovary and has them secrete androgens. And the FSH from the pituitary will go to the granulosa cells and have them secrete estrogens. However, in PCOS, you are going to have elevated LH secretion compared to non-PCOS patients. So you are going to have more androgen production. Also, it does not help that PCOS patients' theca cells in the ovaries are more efficient at converting androgenic precursors to testosterone, elevated androgens as well. The other thing to mention is insulin. So it kind of runs around and just wreaks havoc. Or yesterday when I was playing in the flower jar, and basically it wreaks havoc. So it goes over to the LH and works synergistically to increase androgen production. And in addition, it goes to the liver and inhibits the sex hormone binding globulin production. Remember, this is a protein that grabs some of the testosterone floating around in the bloodstream, and so there would be less of the testosterone. But when you have less sex hormone binding globulin, you're going to have more free testosterone running around able to attach to the androgen receptors. Okay, so take a look at this here. You can tell that PCOS can affect a woman through their entire lifespan. And I think it helps us to have a little compassion on them as on our patients. So you can have hirsutism from adolescence to the reproductive years. They can be struggling with infertility during the reproductive years. And then obesity from childhood throughout the end of life, as well as diabetes and cardiovascular disease can be a problem later on in life as well. And it's not surprising that many of them can have depression and anxiety. So that's something else that we need to think about. So let's take a poll now. Which of the following are ways PCOS can affect Menses and fertility? And we're going to take about 30 seconds to hear what you think. So the options are oligomenorrhea, amenorrhea, reduced fertility, dysfunctional uterine bleeding, or all of the above. My mouse to cooperate once again. Okay. Oops. All right, there we go. So oligomenorrhea, amenorrhea are the most common ways that PCOS affects women. Reduced fertility, like we said, you can have 40% who are infertile, and you can also have a dysfunctional uterine bleeding, risk of ovarian hyperstimulation, and multifetal pregnancy that comes with ovulation induction or assisted reproductive technology, and then you also have the endometrioma. A lot of that is from the unopposed estrogen, that is from them not ovulating regularly, but there's cancer risks for the endometriosis up to 3 times as high. Okay, so you can see this chart here. The insulin resistance is something that is very common among women. And 50% of women with PCOS will have metabolic syndrome. And metabolic syndrome, you can go back to module 1, but again, that's abdominal elevated triglycerides and blood pressure, fasting glucose that are together shown to increase cardiovascular risk among people. Obesity-related conditions with PCOS patients than other individuals. And it's not just BMI related, it can actually also be, it seems to be more related to insulin resistance than the BMI, age, or even testosterone levels. Okay, so these all contribute to increasing type 2 diabetes and cardiovascular risk. So take a look at the percent of women with PCOS have impaired glucose tolerance. The risk of developing type 2 diabetes is up to 8 times higher for women with PCOS than without. And as many as 10% will have type 2 diabetes by their 4th decade. Now remember, PCOS has a heterogeneous presentation. So women who are not obese, who are able to keep their weight down, have less of risk than the people who are overweight or obese. But PCOS patients also have a higher risk for developing gestational diabetes. So that's 20% versus 10% of non-PCOS patients. And then the last little bullet point here, cardiovascular disease. PCOS patients seem to do have a higher pro-atherogenic lipid profile. So that's the high HDL, high triglycerides, low HDL, and that's from the insulin resistance and the elevated androgens. Now you would expect them to have higher morbidity and mortality from cardiovascular disease, but interestingly studies haven't demonstrated that yet. So now hopefully we're convinced that PCOS matters to our patients. Now how do we actually diagnose the person before us? So this is a table that you can see the 3 current ways to diagnose PCOS. On the left you see the 1990 NIH, the original criteria that was developed. Then you see the middle one, what's called the Rotterdam criteria from 2003 that was developed by the European Society for Human Reproduction and Embryology, and American Society for Reproductive Medicine, and then, this is why they call it Rotterdam criteria. And then you have the AE, so the Androgen Excess PCOS Society's criteria from 2006. What they all have in common is that they list hyperandrogenism and ovarian dysfunction as part of the criteria. All require you to rule out other causes that would cause potentially similar symptoms like irregular periods or hirsutism, so that's like hyperprolactinemia, thyroid dysfunction, androgen secreting tumors. All require you to have more than one element to diagnose PCOS. So ovarian cysts, for example, alone are not enough to diagnose PCOS. And none of them list insulin resistance as part of the diagnostic criteria, even though it's commonly associated with PCOS patients, it's not part of the criteria. Okay, so let's go a little bit more in depth. The NIH was developed basically by convening a group of experts and surveying them and seeing, well, what do you think are the key features for developing PCOS? And they came up with chronic anovulation or menstrual dysfunction and clinical and or biochemical signs of hyperandrogenism. The Rotterdam criteria, basically some people thought, well, the NIH seems to be a little bit too broad. What about the people who have polycystic ovaries and don't have regular periods and don't have elevated androgens? And so they went over to Rotterdam, probably took a look at the tulips, and they came up with this criteria, that you need 2 of the 3 here. So you need to have the oligo or anovulation, clinical and or biochemical signs of hyperandrogenism, and then the polycystic ovaries. Lastly, then you have the PCOS Society's criteria, and they spent about a year looking at all the literature, and they were wondering whether you could really diagnose a patient with PCOS when they don't have elevated androgens. And they came up with the fact that you have to have elevated androgens as a key feature for PCOS. And then either polycystic ovaries or some kind of menstrual dysfunction. So this last criteria from 2006 is kind of the middle of the road between the NIH and the Rotterdam criteria. By the way, this is a criteria to diagnose adults. So diagnosing teens is a little bit more complicated, and it's still under development. So basically, many of the symptoms that you have with PCOS, like acne or irregular periods, are common among teens, even if they don't have PCOS. So if you have someone showing up to your office, you want to wait a year or two, to see what happens with their periods. And usually, even in the first year of menarche, they would have 21 to 45-day cycles. So a 90-day cycle would not be really normal for anyone typically. The best thing to do is not really diagnose PCOS among teens with polycystic ovaries or ultrasound. You would basically want to go off an abnormal bleeding pattern and evidence of hyperandrogenism, so persistently elevated testosterone levels, or moderate to severe hirsutism, or inflammatory acne that's treatment resistant. Okay, so let's take a look at some of the ways that you can approach diagnosing PCOS. So typically when a patient comes to you, I'm sure you do a blood pressure, BMI, you could do a waist circumference, usually over 35 inches would be abnormal. And then for your physical exam, you want to look at body hair distribution, acne, male pattern baldness, signs of insulin resistance with acanthosis nigricans, signs of virilization, for example, enlarged muscles, clitoromegaly. Remember that the signs that people have with the irregular periods and the hair growth are usually starting at puberty and are slowly progressing. So a person who suddenly tells you that they woke up and they just are, within a week or two, started noticing hair growth on their upper lip and have a mustache or beard, then you need to think about virilization and potentially an adrenal secreting tumor. Okay, labs here. Now, stick with me here for just a moment. So the labs for androgens, you mainly want to do testosterone. Free testosterone is what most accurately correlates with PCOS, as opposed to total testosterone. So free testosterone is looking at the testosterone running around in the bloodstream. Now, 2/3 of patients will have elevated testosterone too, but the thing with free testosterone is that it's hard to get an accurate level, so you need to know what your lab is doing. Equilibrium dialysis is a gold standard. Direct analog radioimmunoassay, so RIA with purification, is also going to give you accurate results, and so will an online calculator if you have gotten a total testosterone and a sex hormone binding globulin for labs done. Anything else? So the RIA without purification is not going to give you reliable results. And if you're not sure what your lab does and can't figure it out or don't have time, then use an online calculator plugging in the total testosterone and the sex hormone binding globulin results. DHEAS, you typically would only do if you're worried about virilization. Then ruling out other causes are TSH for any thyroid dysfunction, prolactin for hyperprolactinemia, and then you also want to use the 17-hydroxyprogesterone that's looking for a hormone to rule out congenital adrenal hyperplasia. And basically, if that is, that would be, sorry, let me just tell you just for a moment here, that would be a fasting morning test in the follicular phase, so the first half of a person's cycle. Under 2 nanograms would be normal. If it's above that, then you would order an ACTH stim test to diagnose late onset congenital adrenal hyperplasia. We didn't list here, but by the way, if you need to look at whether someone's anovulatory, you can do a serum progesterone test, cycle day 20 to 24. If it's under 3 or 4 nanograms, that would be anovulatory, and you would usually want to do that again to confirm they're truly anovulatory on a regular basis. Okay, and then the fasting lipid, 2-hour oral glucose tolerance test, cholesterol test you see here because of the cardiovascular and metabolic risk that we talked about. Fasting lipids and cholesterol are a good idea, and then the 2-hour oral glucose tolerance test. So it's a 75-gram test, and this is going to help you see if there's impaired fasting, impaired glucose tolerance that you would not be able to pick up with the fasting lipids or the cholesterol, obviously. And ultrasound, you may order that, may not, but usually this would be by transvag ultrasound. Transabdominal will have a harder time picking up the number of follicles, but you may ultimately end up doing that for non-sexually active patients or people who may have cultural decisions to not have a transvag ultrasound done. The Rotterdam criteria, when they came up with looking at the ovaries, basically said you need to have a certain number of follicles of a certain size for it to be officially polycystic ovaries. And that's 12 follicles, 2 to 9 millimeters in one ovary, or increased ovarian size. Now, just to make things more exciting for you, technology of ultrasound has improved over the years. So now AES has new guidelines saying that the threshold for the number of follicles that you need to diagnose the radiologist is going to use to diagnose or suggest PCOS is going to be 25 follicles. And remember with teens, there is no certain criteria about what is normal ovarian size and how many follicles should they have. And so it's really best to steer away from that among the teens. Okay, so hirsutism, very common in PCOS. This is the Ferriman-Galloway scale that you can use to figure out what is normal and what is considered hirsutism. It rates the different body areas on a scale of 1 to 4. Anything 8 and above is considered hirsutism, and 16 and above is considered moderate to severe. Now, it's not a perfect scale, but it hopefully is helpful. It's obviously subjective. It doesn't take into account all androgenic areas like sideburns and buttocks. And thirdly, how do you rate the hair growth on a body part where someone's already waxed or shaved that area? So it has some limitations to it. Okay, pool number 2. True or false? Is drug therapy a management option for PCOS related metabolic and cardiovascular complications? And see what you think, true or false. We're going to wait a few more seconds here to give you all a chance to put down your phones and answer this question here. Okay. All right, so 94% of you thought that was true, and the answer is true, and let's talk about that here. Hopefully this will be helpful now. Let's go back to, oh, there we go, the mouse is starting to wake up a little bit more. Okay, so since we talked about metabolic and cardiovascular risks being more common among PCOS patients, you definitely want to do regular screening for that with BMI, waist circumference, blood pressure, fasting glucose, oral glucose tolerance tests, lipid profiles, and lifestyle modification is key for PCOS patients. There is no medication to treat all problems or reverse PCOS, and since the underlying pathophysiology is not completely understood, treatment is going to be aimed at addressing their various symptoms in general. Now, lifestyle modification and weight reduction is going to do a lot for them. It's going to decrease androgen effects, increase ovulation, improve insulin sensitivity. As little as 5 to 10% of body weight can improve menstrual regularity and metabolic risk factors. So if your patient were to decrease their calories by 500 to 1,000 a day, that would result in a 7 to 10% weight reduction over 6 to 12 months. So it's important to remind them that you want slow weight loss with healthy lifestyle changes that they're going to be able to sustain, because yo-yo dieting is not going to help them in the long run. So remember the practical things that you already know. Ask them about their fruit juices, their lattes, their soft drinks, their portion sizes. If you want a good visual to show them, Harvard School of Public Health Healthy Eating Plate is a great visual. About half, it basically shows you that half the plate would be veggies, half of it would be carbs, half of it would be proteins. When it comes to exercise, help them find something that they enjoy, and so it's not that they're torturing themselves every single day. Remember, 30 minutes of exercise will usually maintain their weight. If they want to lose weight, they need to do more than that. And weightlifting to boost their metabolic rate through increased muscle mass can also be a good way to go. Okay, drug therapy, metformin. This is a big one, an insulin sensitizing medication. And this is appropriate for people who have impaired glucose tolerance or type 2 diabetes. That's when you want to think about metformin. It seems to have the safest risk-benefit ratio of the insulin sensitizing agents. Not officially approved for PCOS, but it can work for impaired glucose tolerance and type 2 diabetes. Remember that you want to slowly titrate up the dose. Usually it's 1,500 to 2,000 milligrams a day. And you want to slowly titrate it because of GI side effects like diarrhea, nausea, or bloating. And people are usually encouraged by the fact that they do lose some weight on this. Okay, so now let's talk about menstrual cycle regularity and fertility in PCOS. So we just mentioned that some weight reduction can help improve menstrual cycle regularity and fertility. And let's break up management into the ideal situation where a woman knows whether or not they want to conceive, because we know that's not always a reality. Remember, this is a good idea to screen people and ask them regularly, are they wanting to conceive anytime soon? And the one key question developed by Oregon Foundations for Reproductive Health is one way to go about that. You can ask them, would you like to become pregnant in the next year? If they say yes, that's the column that you see before you on the right. If they say no, that's the column before you on the left. PCOS, okay, so let's start with the attempting to conceive side, because most of the time you're going to refer those patients out to OBGYN or infertility treatment. So PCOS subfertility and infertility is likely related to many factors. So the obesity and metabolic abnormalities can lead to anovulation, but they also are talking about whether there's endometrial receptivity, oocyte availability problems in PCOS, not just the anovulation. If these patients get pregnant, which we hope that they do when they want to, then they do have a higher risk for GBM, pregnancy-induced hypertension, preeclampsia, and miscarriage risk seems to be the same for non-PCOS patients and PCOS patients. So one thing you can do if they're not cycling regularly is help them work on their lifestyle and losing some weight, because that make a big difference. Losing weight is less clear of a solution for people who already are at a normal weight. When you refer a patient to OB and they need some ovulation induction, then the first line treatment will be Clomid, so clomiphene citrate. This is an anti-estrogen that basically is going to be blocking estrogen's negative feedback at the hypothalamus and the pituitary. That leads to elevated FSH and ovulation. And usually you would have a 30 to 50% pregnancy rate after 6 months. If that doesn't work, then second line options are gonadotropin or ovarian drilling. So gonadotropins, basically they would get FSH injections to help them ovulate. Now this would be your patient's chance to have, make it big, because they can have those 3 or 4 or 5 multifetal pregnancies, and then they could become famous that way. But usually, because of the multifollicular ovulation, multiple gestation risk, the gonadotropins are not first line. Ovarian drilling basically is destruction of part of the ovary that has a lot of the androgens that ultimately will help them lead to ovulation. Ovulation induction of any kind does increase risk for multiple births and those related risks like gestational hypertension, postpartum hemorrhage, preterm birth. Okay, so that's all I'm going to mention about the infertility treatment. What you're going to deal with more are people who are not wanting to conceive and who are going to go on some sort of birth control. And as they get healthier and lose the weight, they will become more fertile. So remember that when you're selecting birth control options for a patient, the birth control can help them with more than just preventing pregnancy. It can help with cycle regulation, endometrial protection, as well as reductions in some of the hirsutism and acne that they're so distressed about. How do you select a birth control method? So the CDC has an effectiveness birth control chart that you can go to their website and you can print that off. basically you want to find a method that's the most acceptable and effective for them. So the first tier, so there's 3 tiers. Tier 1 would be the most effective. Those are like the IUDs, the implants. Tier 2 would be pill, patch, and ring, and tier 3 are like condoms or withdrawal, for example. Now, it just so happens in PCOS, usually the first-line treatment is the birth control pill, the combined oral contraceptives, because it will give them birth control and help them decrease androgens in their body. Obviously, if the patient has contraindications to this pill, then you would go with a progestin-containing birth control, and that would give them fine birth control, but it would have weaker anti-androgenic results. So how does a combined oral contraceptive work? And actually, by the way, it can also work not just for testosterone, but for even some of the adrenal origin, the DHEAS. So the estrogen increases sex hormone binding globulin, and remember that's going to make less free testosterone in the end. And the progestin component of the pill is going to help reduce LH secretion. The net result is that the combined oral contraceptives are going to be anti-androgenic, mainly from the sex hormone binding globulin. So it doesn't matter what pill you use, so no single one has been proven to be better than another. Usually you would pick a low dose one, a 20 to 35 microgram one. If they say they can't never remember to take a pill, then and they would want to do a ring or a patch, that's also a fine birth control option, but probably has less anti-androgenic effects because it bypasses the liver and how it's metabolized. Now, some progestins are chemically related to testosterone and some aren't. So theoretically, the idea of giving them one that's not related to testosterone makes sense. So that's like the norgestimate, the orthocycline, the trinesa, the desogestrel like the Merced or the Cariva or the drospirenone, which is like the Yaz or the Yasmin. There is some concern with the elevated blood clot risk, but overall it's still low. Okay, and when someone is on birth control because of birth control and for decreasing, for example, hirsutism, that's where you would add on an anti-androgen. You would only do that after them trying a birth control pill for 6 months. So that's the hair growth cycle, and then you could add on something like spironolactone. I'll talk about that in a few slides. And lastly, you see metformin here. That's mainly if they have impaired glucose tolerance or type 2 diabetes. You don't just give that to them otherwise. Okay. Let me say one more thing, which is related to endometrial protection. So if for some reason your patient is not wanting to go on a birth control pill and you need to somehow protect their endometrium, then you want to, in your mind, and explain to them that having a cycle like every 2 to 3 months is important to prevent the hyperplasia and the carcinoma. Patients usually are psyched when they are not getting regular periods and don't know that that's actually a dangerous thing if they are not on some sort of method, birth control method that's keeping them from having regular. So you could do a medroxyprogesterone acetate 5 to 10 milligrams, 10 to 14 days, or you could do a micronized progesterone 400 milligrams for the same amount of time, 10 to 14 days. Obviously, rule out pregnancy before. The micronized progesterone is made in peanut oil, so if they have a peanut allergy, don't go that route, and it's usually good to give at night because it can help people sleep. Okay, so we talked about the combined oral contraceptive being the first-line treatment usually for people, but how do you actually know that's safe for the patient before you? Well, CDC, lucky for you, has come to your rescue. In 2010, they came out with the U.S.MEC, the medical eligibility criteria, and here you can look up certain conditions and characteristics by birth control method, and you normally will not need a magnifying glass. Okay, so they're basically rated on a scale of 1 to 4. A 1 is perfectly acceptable. A 4 is an absolute contraindication. So, for example, you would not put someone on a combined oral contraceptive if they have migraines with auras, or if they're a smoker over age 35 and they are smoking over 15 cigarettes a day. What this can help you see is that you can look up how obesity affects whether the pill is appropriate, how hypertension does. and that can be giving you the confidence that you need to make sure that you're prescribing them something that. So obesity is not a contraindication, that is a 2. Basically, 4 is an absolute contraindication, a 3 is better not go that route, but if there's nothing else acceptable, you could consider it. Really, you want to stick with the 1s and the 2s. So diabetes, for example, a combined oral contraceptive is a 2, unless they have had it for over 20 years or they have retinopathy, neuropathy, for example. And you can look at this online, and there's actually an iPad, iPhone version of this app that you can look at too. Okay, so a few little words here before we are close to wrapping this up and moving to our case study. Now, remember to tell patients that optimizing their health before they get pregnant is important, because you want to have them have a healthy pregnancy and a good experience and good outcomes. Patient-centered decision-making is vital, so help them pick a method that will work for them. Christine Dellendorf from UCSF likes to ask patients, what are you looking for in a method? So is it that you don't want to have regular cycles? Is it the convenience? Is it the reduction in hair growth? So work with a patient. Since many of our patients who have PCOS are obese, it's worth mentioning that obese women do ovulate regularly. They have sex as often as the rest of the world, except maybe parents with small children. And as far as birth control effectiveness, combined oral contraceptives seem to be as effective. They might be a little bit less effective among obese women. The studies are conflicting about that, but some birth control method is better than none. And as far as the implant, the St. Louis Choice Project has found that the implant, so the Nexplanon, is as effective in overweight and obese women as non-obese women. Okay. Now, people obviously don't want to gain more weight if they're already overweight. They're usually really self-conscious about their weight. And the ACOG Obesity Project has shown that the pill, patch, and ring have no associated weight gain with it. The Paragard, so the non-hormonal IUD, no weight gain. The levonorgestrel IUD, like the Skyla or the Mirena, for example, may have a small weight gain, but it's pretty tiny, maybe a couple pounds. Implant, probably no weight gain. The one that really would lead to weight gain in most people would be the depot, and weight gain with it. Weight loss, since it stays in your system for so long, is pretty hard to combat. Okay, so this is the last slide that we're going to have before we meet Kara, our case study. And hirsutism and acne, basically they're the mechanical methods, like shaving, waxing, plucking. The thing to know is that the primary drug treatment for hirsutism is going to be your hormonal contraceptive, because reducing the androgens in the body is going to be vital. And again, you want to give it 6 months before you throw on an anti-androgen. So anti-androgen is like spironolactone, is what's most commonly used. It's basically, the dose would be about 50 to 200 milligrams per day, twice daily. It's going to bind to the androgen receptors, and it's a testosterone antagonist. It is a teratogen, so you want a patient on birth control if they use this method. And it's going to be helpful for hirsutism and acne, and it will take about 6 months to see some max results. It can increase menstrual frequency, and use caution with people with renal impairment, because it can lead to hyperkalemia. Okay, now sometimes people want a little bit of faster results. They have prom coming up soon, and they don't want to have to deal with shaving right before. So Vinica, the eflornithine cream, 13.9%, can work well on the face and chin. Usually they would use it twice a day, and it inhibits the enzymes in the skin, and so it inhibits the cell division and the synthesis. Results are usually 4 to 8 weeks. The bad news is that if you stop it, slowly the hair growth will come back, but it at least can give them something in the meantime. And then there are all the other permanent hair removal options, like electrolysis, so inserting a little electrode in the hair follicle that destroys it. It's good for small areas that don't have a lot of hair, or laser, which can be a little bit expensive for people, but at least give them some other long-term options. I will just leave this here for you to see that when you have a patient who does say that they're interested in getting pregnant, you want to make sure they are off of these various medications. Okay, so here is our case study, Kara, and she's a 26-year-old G0, P0, so she's not been pregnant before. I personally thought it'd be more exciting if she were a circus performer, but we made her much more sophisticated. She's an accountant. And she's here for a well woman exam and complains of hair growth. That started a few years ago. She used to shave and tweeze the hair follicles and has irregular periods, has that about 5 periods a year. She wonders if that's okay. Has had weight gain over the past 4 years, and she's just very self-conscious about her weight and her hair growth. She has no significant past medical or surgical history, is not a smoker, monogamous with her male fiance, doesn't want to get pregnant now until she finishes the grad school, so that'll be another 2 to 3 years. She's used condoms in the past. She's not using any now. She's not sure if she could even get pregnant, so why bother? Her blood pressure is a 130/88, but when you recheck it, it's like 125/82. She had just run up the stairs, and so it was a little bit high. Her BMI is 28. Her waist circumference is 37, so that's over the 35 that is in the metabolic syndrome criteria. The Ferriman-Galloway score shows 17, so that's the moderate hirsutism. Her pelvic exam is normal, and she's not depressed. You have her come back a week later after she does her lab, and her 2-hour oral glucose tolerance test is impaired, so it is abnormal, and her fasting is also impaired, so she doesn't have type 2 diabetes, which at least is good news. Her lipid profile is mildly elevated, LDLs, her free testosterone is elevated, and you've ruled out other causes like thyroid, prolactin, and late onset congenital adrenal hyperplasia. You didn't order an ultrasound because you already know she meets the criteria for PCOS, so she has the irregular periods and the hirsutism. Okay, so poll number 3. After discussing her lab results, do you recommend pills for combined oral contraceptives for Kara? Yes or no or not sure. And let's give you a few more seconds. Okay, so 91% of you said yes, I agree with you. 3% said no, and 6% said not sure. Okay. Let's see if I can move along here. Okay. So I agree we can start the combined oral contraceptive to regulate her cycle and also help with the hirsutism. She doesn't have any outright contraindications to it. And basically, you want to tell her that it will take some time for the hirsutism to improve. You also want to tell her that it will take, in the first few months, she may have some irregular periods. That's common when you start on a pill. And you encourage her to increase her activity. She thinks that she can walk 30 minutes a day 3 times a week, which if she's sedentary at baseline, it seems a little ambitious, but when you ask her further, she's very confident that she'll be able to achieve that because she just bought a puppy yesterday and she needs to go out with her. You refer to her nutritionist, and she feels like she needs some help in modifying her diet. She obviously is a super ambitious person because she is tackling both the exercise and the nutritional lifestyle changes at the same time, which most people can't do at the same time. And because you asked her about how she feels about her body, and she told you that she felt really just a lot of self-hatred and just did not like how she looked and started feeling unkind towards herself, you sent her to and you plan tend to follow up with her in 3 to 4 months. You know, you definitely don't want to lose track of these patients. You want to encourage them, and you'll want to do a blood pressure check for starting the pill. That usually would be 2 to 3 months after as well. I should also say the SPR, the selective practice recommendations, are going to be very helpful for you. It tells you that a patient does not need a pap smear before you start them on a pill. And you don't need to do a pelvic exam on someone before they start a pill. And it tells you when you can start a pill the same day and when you can't. So at the back of the resources here, you'll see that. Okay, and we are running short on time, so I'm going to quickly just point you to this resource list here. ACOG at the very top has a good practice recommendation for you to use, also has facts that you can give the patient. Boston Children's Hospital has really good medically supervised online chats monthly for PCOS patients. It's for younger people ages 13 to 22, but they have a very good free printable booklet on PCOS. It's quite extensive. And then at the bottom, you'll see the U.S. medical eligibility criteria and the SPR that I mentioned that are great resources for you. All right, and that's all I have for now. Let's see if we have any questions.
Thank you, MSA, for this excellent presentation. At this time, we'll open the floor for questions. To ask a question, please enter it into the question box in your control panel.
Okay, so let me scroll here and see what we have. Just one moment. Hold on. One question is, what is evidence of doing a hemoglobin A1C? That's what I usually order instead of a 2-hour glucose tolerance test. A1C won't get at the impaired glucose tolerance as accurately, so the recommendation is the 2-hour. Let's see here. Let's see if I can look at another question. Any particular OCP better? Yasmin, you can use Yasmin. People have some concern about the elevated blood clot risk on it, though the absolute risk is still pretty low. When you look at the studies, they haven't actually shown that any are superior to the other, like which progestin. I think theoretically the idea of using an anti-androgenic progestin is a good idea, but basically, studies haven't shown one being better than another. Let's see this one. So someone asked whether there's a link between PCOS and depression and anxiety. Should patients with PCOS be screened for depression and anxiety? I think that's a great idea. There is a link. It's unclear whether it's something related to the syndrome itself that's hormonally or just as a result of the various experiences people have with PCOS, but I think it's a really good idea. And also screening for eating disorders is a really good idea. Great question. Let's see what this next one is here. Okay. That was Samantha's question. Dose for metformin in PCOS usually is 1,500 to 2,000 milligrams a day. Let's see. Well, let's see here, who was it? I should probably say who. So Haley asked whether progestin-only birth control methods provide endometrial protection. Yes. Basically, you just don't want them to be without anything. Let's see. So if a patient is taking a drospirenone-containing OCP, would you switch to an OCP with another progestin if adding spironolactone? I don't think you necessarily need to, but you would start with a lower dose of the spironolactone. And let's see, Emily. A great question. Is there an increased risk of miscarriage for patients with PCOS? So there's a lot of conversation about that, and so far what it seems, the answer seems to be no when you correct for BMI, for example. So there doesn't seem to be an increased risk. Oh yeah, so Monica wanted to know, how can you repeat, so can I repeat how to interpret testosterone values? Okay, so testosterone, you want to go for the free testosterone that most accurately will correlate with PCOS. So total testosterone is elevated in 2/3 of patients with PCOS also. You want to go with the equilibrium dialysis as one of the methods. Or you want to use RIA with purification. But if you just don't know what your lab's doing, you can't ever get a hold of a lab manager, then the easiest way to go is just calculate the free testosterone. And what you would do is order a total testosterone and sex hormone binding globulin. You can actually go online and find a calculator there and plug in those numbers, and you will be able to get accurate results for free testosterone. Let's see here. So Maria asked, what are your experiences with prescribing a combined oral contraceptive and DBT? What about people with elevated lipids, borderline blood pressure, obesity? So there is a higher risk for people, I think it's about a 6-time higher risk for people who are on pills than if they're not on pills in general for having blood clots. You obviously want to be cautious, and people who have elevated lipids and borderline blood pressure and obesity, it kind of depends on the patient before you, but it is a risk, and it's less of a risk than if they got pregnant, and because you automatically have hypercoagulable state at that point. But it is a risk, and there is some talk that PCOS patients naturally may be a little bit more prone to blood clots anyway. So I think that I would be cautious. And that might not be as direct as you want, but I would just leave it at that. Okay, so let's see. Rachel's asking, if a PCOS patient is trying to conceive, would you have her stay on cyclic progestin for endometrial protection, or would you discontinue while she's trying to conceive? Basically, you do need to make sure she is having regular cycles. So if she doesn't have a period for a few months, do a pregnancy test first, and then you can do a withdrawal bleed. Priya, I'm not sure how much more time you need. I know we're kind of short on time. Do you want me to keep answering questions, or do you want to wrap it up?
I think that that's a great overview of our questions, and if we could move on to the summary, then that would be great.
Sure. Okay. Okay. So basically, PCOS is, oops, I jumped again. Okay. PCOS is common among the women that we're seeing, and in a busy private practice setting, it's important to take the time out to hear their concerns, help them reduce their risks, metabolic and cardiovascular, and also their reproductive risks as well. And we want to help manage their symptoms, and hopefully we covered enough that you feel like you have some ideas on how to do that. PCOS is, really troubling for a lot of people, and they just want to feel like their peers who are out running around and are carefree about their health. So remember to use your resources and the nutritionists, your nurses, and hopefully together we can all help our patients have a quality of life that we all want them to have.
Okay, thanks very much, Imeshe, for this wonderful presentation, and thanks to all our participants for joining us today and for submitting such thought-provoking questions. In just a minute, I'll tell you how to collect your certificate. But first, I'd like to direct you to our upcoming webinars in this series. The next webinar in ARHP's Managing Diabetes course will be held on May 11th at 1 p.m. Eastern and will be presented by Dr. Lori Gowron. Dr. Gowron is a specialist in family planning for women with chronic conditions, and she'll present on contraceptive use and preconception counseling for women with diabetes. We hope you'll also join us for the Diabetes FAQs webinar on June 8th at 1 p.m. Eastern. During this webinar, we'll have an opportunity to explore questions we didn't have a chance to address today. If you'd like to check out more of ARHP's educational resources, please visit our website at www.arhp.org. And all of these resources, including today's webinar, are brought to you free of charge. Please help us to keep these resources open access by becoming a member of ARHP today. And now to the post-test survey. You will receive an email from GoToWebinar 1 hour after this session ends. It'll contain a link to the post-test survey. After completing the survey, you'll be able to print your continuing education certificate. Please be sure to print before closing the window. If you have any difficulties printing or you aren't able to retrieve your certificate later, please email us at education@arhp.org. Thank you again for joining us today. We hope that you will take part in other live and on-demand sessions hosted by ARHP.